Early diagnosis in oncology can make the difference between a curable disease and a late diagnosis, when treatment options are limited and therapies become more demanding. In lung cancer, the time factor is even more crucial, as the disease can remain silent for years, and by the time a persistent cough, shortness of breath, or chest pain appears, the condition is often already advanced. This is why oncologists emphasize the importance of structured screening for high-risk individuals, particularly heavy smokers and former smokers who have recently quit. The primary tool is the low-dose spiral CT scan, a rapid, non-invasive radiological test that uses minimal radiation and allows for the visualization of even very small nodules in the lungs at a stage when surgery or targeted therapies are easier to address, increasing the chances of recovery. The idea is to offer this screening once a year, including it among the services guaranteed by the National Health Service for those who meet defined criteria of age and cigarette consumption, so that it is not reserved only for those who can afford it, but becomes a true public health program. Specialists are calling for lung cancer screening to be included in the essential levels of care, alongside screening for breast, colorectal, and cervical cancer, because evidence shows that early diagnosis with spiral CT scans significantly reduces mortality and the overall burden of the disease. Studies indicate that compared to chest X-rays alone, this test can reduce lung cancer mortality by approximately 20%. The protocols identify ideal screening candidates as people between the ages of 55 and 75, with a long history of smoking, for example. Those who have smoked about 15 cigarettes a day for over 25 years, or about 10 cigarettes a day for over 30 years, including those who quit less than 10 years ago, because the risk doesn't disappear immediately when the pack is thrown away. Of course, screening is no substitute for primary prevention. Quitting smoking remains the most powerful weapon for protecting the lungs, but for those with many years of smoking, periodic surveillance with CT scans can provide a safety net for catching the disease at the first sign when it is still localized and more manageable. Alongside the lung issue, oncologists emphasize how a similar approach to early diagnosis and personalized care has already transformed the history of breast cancer. In Italy, thanks to organized biennial mammography programs for women in the recommended age range, thousands of lives have been saved, as tumors are often identified when they are still too small to be palpable, but are already visible on X-rays. This is where genomic tests come into play, analyzing the expression of groups of genes in tumor tissue and helping predict the risk of recurrence over time. These tests are particularly useful for hormone-responsive forms of breast cancer and are performed after surgery to determine whether hormone therapy alone is sufficient or whether chemotherapy is appropriate. In many cases, test results show that the risk of the disease returning is low and that chemotherapy would not offer any real benefit, thus allowing many patients to avoid its side effects and follow a milder but still effective treatment plan. One of the tests currently available has been shown to significantly reduce the need for chemotherapy, freeing up resources for the healthcare system to reinvest in other areas, while simultaneously improving quality of life. For this tool to remain accessible, however, dedicated funding must be adequate to the actual number of people who could benefit from it each year, so that genomic testing becomes a permanent part of clinical practice. Ultimately, for both lung and breast cancer, the message is the same. Investing in early diagnosis and personalized care saves lives, makes therapies more tolerable and targeted, and uses resources more rationally, transforming the fight against cancer into an increasingly effective and far-sighted effort.